So we'll move through these slides quite quickly. But we're going to hear a lot in the next 5 years about maintenance therapy in acute myeloid leukemia. It's something we view as standard in ALL. It's not used in AML. It's certainly not used as standard. But I think it's a very interesting area. And I think it's an area where there's going to be a lot of talk and probably change in clinical practice. In the interest of time, I want to just get onto the clinical data, because I think we're running a little late. So the question is, if that can prevent the disease relapsing. There's some data from a French group using androgen maintenance. And very interestingly, there are now one, possibly two randomized studies showing that azacitidine given subcutaneously can improve disease-free survival. So these are patients not fit for transplant or in whom transplant's not indicated for whatever reason, who have induction, go into CR, and then have a couple of courses of consolidation, and they're randomized to AZA for a year or not. This is the HOVON study that showed improvement in disease-free survival. Interestingly, no difference in overall survival. The previous androgen study didn't show any difference in overall survival. So I think up until about 4 weeks ago, just 4 weeks ago, we were still saying, well, I don't know, it's quite interesting, it's a disease-free survival signal, but there's no difference in overall survival. There isn't any established agent. Until we had this on the Celgene website, which was the preliminary results of a late-breaking abstract that was published 2 days ago on the ASH website, and was the result of the QUASAR AML 001 study, in which patients with AML were randomized after induction and consolidation chemotherapy to oral azacitidine, CC486, and they received it for 2 years. We haven't seen the data. It's going to be at ASH in 3 weeks. Expect a big splash, because apparently it shows improved overall survival in patients who get CC486, as well as improved disease-free survival, and it's well tolerated. So if this data, once we've had a chance to scrutinize it, is as good as it looks, there's every chance that CC486 will be licensed by the FDA. This is a very strong signal. P-value is quite impressive. And that will mean that we have a maintenance therapy. Apparently, the benefit is independent of cytogenetics, independent of MRD. It works across the board. We will have a new maintenance therapy for people who don't go to transplant. So watch this space. And then turning to maintenance in patients who've had an allogeneic transplant, an area that I've been working in for a number of years. If you think about how we reduce the risk of relapse in patients who have a transplant, and relapse is the major cause of treatment failure, I would suggest to you that there are 3 or 4 ways we could do this. We know that the MRD status of patients going into transplants a risk factor for relapse. Well, you could do something about that, couldn't you? You could think about it. There's no randomized data, but you could, in principle, intensify treatment in MRD positive patients before they go to transplant. Second is, you could do something about the conditioning regimen. We know if you give a more intensive conditioning regimen, you reduce the risk of relapse. The problem is you get more toxicity, but we could ideally find an augmented anti-tumor effect in the conditioning regimen without increased toxicity. And then finally, I suggest you could do something about the graft versus leukemia effect through a maintenance strategy. I think this is the most exciting option. And I want to remind you how powerful the graft versus tumor effect is. This is a study we did in the UK where we looked at patients who had a RIC allograft for AML, and our fellow painstakingly looked at the cyclosporin levels in the first 21 days, and she calculated an area under the curve for these patients. And the blunt and simple observation is, if you have a high cyclosporin level post-transplant, higher than the median, your risk of disease relapse is 45% higher. This is exactly what Bacigalupo showed in the setting of a myeloablative transplant. But if we had a drug whose deployment reduced relapse by 40%, we'd be jumping up and down. We don't talk about graft versus leukemia that way, but maybe we should. So what can we do then to augment the graft versus tumor effect? How can we help it? Well, I propose to you that it takes months for the graft versus leukemia effect exerted by donor CD8 positive T cells to become operationally active. The T cells need to expand, it takes some time, and that some patients, particularly those with fast kinetics of relapse, will relapse before there's an operational graft versus tumor effect. So what can we do to fix that? Well, this is the problem. It takes a time to establish a graft versus leukemia effect, as I show here. If relapse happens before that, you've missed out on the graft versus tumor effect. So we could either therapeutically intervene just to push back the timing of relapse, to manipulate the kinetics of relapse, to buy time for the genesis of the graft versus tumor effect, or we could give a drug that accelerates the GVL effect. So we've been very interested in looking at azacitidine in this context. We were very interested in our lab to show that azacitidine upregulates the tumor antigens that may be recognized in a graft versus tumor effect. And we therefore postulated that azacitidine might be an interesting drug to use post-transplant, partly because it has a anti-tumor activity. It's active in AML, and it may just push back relapse, giving you time for the graft versus leukemia effect to come in. But secondly, because it may upregulate tumor antigens which are recognized by donor CD8 T cells. So we are very interested in pursuing azacitidine as a maintenance strategy in AML, and I'll talk about that in a minute. But the area, of course, where everybody's talking about at the moment is in FLT3 positive AML, where there's some quite interesting retrospective data that patients who get Sorafenib post-transplant, in historical comparisons, seem to have a lower relapse rate. There's a randomized study from Germany that looked prospectively and suggested better outcomes if you got Sorafenib post-transplant. It's a good study, but it has limitations. Small numbers and no MRD. So what we need is a good randomized trial. And that study is accruing at the moment. I don't know if you're putting patients onto it. It's led by Mark Levis, BMT, Clinical Trials Network in the US, 1506. And that is randomizing patients who are FLT3 positive, having an allograft, to gilteritinib maintenance for 2 years. It's going to stop accruing next year, and we'll have an answer to this question. I, at the moment, don't think that post-transplant maintenance with FLT3 inhibitor is standard of care. We don't know if it works. We haven't got any randomized data. We're not sure which patients it works in, and there's quite a bit of toxicity. So get back to azacitidine. As I said, this is an area where we think there's quite considerable promise, and we, along with a couple of centers in the States, were the first to look at oral azacitidine, CC486, as post-transplant maintenance. It's well tolerated. And we're now in the UK delivering a randomized trial of post-transplant CC486 maintenance called Amadeus. People are going to get CC486 for a year post-transplant, or placebo, 320 patients, and we'll have an answer, I hope. And then finally, I just want to draw your attention to the emerging importance of new treatments in transplant, new treatments that promise to reduce the risk of relapse, either as maintenance or as conditioning regimen or pre-transplant therapies. This was a very interesting poster at ASH a couple of years ago that actually showed how many patients would be needed to be recruited to the current randomized studies of FLT3 inhibitors. And they showed that the number of patients far exceeds those who are recruited currently to clinical trials, because only about 5% of patients who've had a transplant go on to a randomized study. So this and other factors made us in the UK think we need to be a little bit more professional about how we deliver prospective randomized trials in transplant. And we've set up a national trials network called Impact, with a hub in my unit in Birmingham, and 20 sites across the UK, 10 of whom have a funded research nurse, to create a catchment region of 20 million to allow us to do randomized studies. So this is an initiative that was launched just 2 years ago. We've already randomized 200 patients on 3 major studies, and I want to show you what can happen when you have a transplant network. This is our first trial, randomized study, patients allografted for AML to get DLI or not. This was a failing study until we opened the Impact network with research nurses in these big centers all recruiting to the same study. Up until we opened Impact, you can see the actual accrual is the red line. Essentially, nobody was being randomized. As soon as you open up the study, you can see that there's a transformation in recruitment, and the study is now over-recruited and closed. The only randomized study of DLI yet done in the setting of AML. And that's what transplant networks can do, and that's why we need them. So in conclusion, I think it's important that we are thoughtful about the important emerging role of maintenance. I want to draw your attention to the CC486 data that is breaking in the setting of patients who don't have a transplant. This is likely to be future standard of care. I also think it's very possible that randomized studies in the next 18 months will show that patients after transplant for FLT3 do better with an inhibitor. We don't know that yet, but I think there's a good chance the randomized studies will show that, but we need to wait for the randomized data. It's also possible that other agents post-transplant, such as CC486, may improve outcome, but again, we need randomized studies. And finally, I think as a transplant community, and this applies to all of us in the room, we need to be thinking about how we open up prospective randomized trials to assess strategies to improve transplant. It's not enough that we rely on randomized trials of new drugs in leukemia to adopt them into our practice. We must have the same rigor in terms of improving transplant outcomes. So with that, I'll thank